So I'll pass the floor now to Professor Supten. We'd like to hear the story of how you were able to establish as a country HL7 FHIR as a interoperability framework. So Professor
Yeah,
Supten.
I won't speak for long, maybe about 20 minutes or so, but I'd like to have more interactions. So that's usually how I do. So I'd be talking, as you can see, about HL7 FHIR uptake in the Indian context. Particularly, we are now having what is called a National Digital Health Mission, and so how we are really trying to leverage FHIR in that. So I'll give a very brief introduction, then I'll try to contextualize our NDHM with what we have, a National Digital Health Blueprint that came out about just less than 2 years back. That was in November 2019, and how this NDHM is being built over that. Then we'll also try to find out the synergies that's happening. So HL7 India is now quite active, trying to lead activities on FHIR. We have a National Resource Center for EHS standards. That's actually in CDAC Pune. So it's essentially funded by the Ministry of Health, although the CDAC is something that is part of our Ministry of Electronics and Information Technology, but it has been acting as a National Resource Center for EHS standards. It's also the National Resource Center for SNOMED City, and they have been working on HL7 for a long time, HL7 DICOM, now SNOMED City, and they're trying to incorporate all the other standards which India is trying to develop on. And our National Digital Health Mission, the NDHM, is being led by an organization that's the National Health Authority. So this National Health Authority is leading the National Digital Health Mission. So I'll try to talk about the interconnections and then highlight some of the explorations going on for how FHIR can be incorporated in activities now that's gained the maximum highlights globally, that's COVID-19 vaccination. So that's how, but most importantly, as I said, we'll be spending more time on question and answers. I had been in this standards field now for more than a decade. I had been writing about it, trying to implement it. I was with the Ministry of Health for nearly 5 years. So during that period, we brought out the National Health Policy 3rd edition in 2017, where in the National Health Policy of India 2017, it was said that the National Digital Health Authority will be set up to regulate, develop, and deploy digital health across the continuum of care. I mean, essentially to set up a national digital health ecosystem. The authority is yet to be in place, but already we have some activities and products. So National Digital Health Blueprint is the major one. Historically speaking, the first document related to health information technology in India was way back in 2003. That's almost 2 decades back. That was called ITIH, Information Technology Information Infrastructure for Healthcare. And that also was brought out by the Ministry of Information Technology. At that time, it was called MIT, or Ministry of Information Technology. Now it has transformed into Ministry of Electronics and Information Technology. And over the 16 years, as I said, towards the end of 2019, we have got a National Digital Health Blueprint. Now, Blueprint is, of course, it's a huge document. It talks about all the things. But what I'm most interested in is the standards. And I think AeHIN has also been doing a lot of activities on standards. So the Ministry of Health and Family Welfare in India had been recommending standards since August 2013. Then the guidelines were revised in December 2016. Because India became a country member for SNOMED City in 2014, March 2014. So in the 2nd edition, we have SNOMED City as one of the standards. So what the National Digital Health Blueprint, which came out another 3 years later, that's 2019, added to the list of standards recommended by the Ministry of Health and Family Welfare of the Government of India is the HL7 FHIR Release 4. So all these standards are being made available through the Bureau of Indian Standards, which is the Indian equivalent to ISO and IEC and various other standards developing organizations. So the standards recommended by the Ministry of Health and Family Welfare are available through the BIS, the Bureau of Indian Standards. And of course, many of the standards are available directly from the SDOs. So getting the standards is not the point, but of course, adoption is still a big problem. So National Digital Health Mission was envisaged as the implementing arm of the National Digital Health Blueprint. And it was formally launched last year on 15th August, our Independence Day, by the Honorable Prime Minister. And the NDHM, or the National Digital Health Mission, is based on the principles of health for all, inclusivity, accessibility, affordability, education, empowerment, wellness, portability, privacy, and security by design. So it's going to build the building blocks into an integrated digital health infrastructure. There are 6 key building blocks or applications. The first is the health ID, and I'll talk more about it later. We have a DigiDoctor. We have a health facility registry that is now being developed. Personal health records. Again, personal health records are available in various forms, but we are also trying to work on some standardized and easily available ones from the government as well. Then we have telemedicine. Telemedicine got an impetus during this COVID-19 pandemic. So last year, we had officially telemedicine practice guidelines from the medical authorities, the Ministry of Health and Family Welfare. It was duly notified in the Gazette of India. And e-pharmacy. E-pharmacy is again another thing that has been going on in various scales throughout our country. So all these 6 key building blocks, health ID, DigiDoctor, health facility registry, personal health records, telemedicine, and e-pharmacy together will form the National Digital Health Mission. And it's supposed to bring together disparate stakeholders and radically strengthen and change the India's healthcare delivery landscape. I think COVID-19 has acted as the CTO globally, the Chief Transformation Officer, and the amount of disruptions it has caused is unbelievable. And 2 of the domains which have been disrupted most by this COVID-19 pandemic have been health and education. So globally, we are having to look at how to deliver and impart health and education. So in the National Digital Health Mission, and this is a very welcome news, particularly for the developer community, there's a sandbox environment. So the National Digital Health Mission is offering a sandbox environment, and anyone, any individual or organization who's planning to develop an API, application programming interface, the APIs to interact with the NDHM, are welcome to come here and experiment with their APIs. So this NDHM sandbox environment is being used widely by various people, individuals as well as organizations. Then in the National Digital Health Blueprint, some of the things which were mentioned about particular FHIR profiles. We'll have national profiles. So NDHM profiles for FHIR implementation. These have been developed. In fact, last year in July, we had held a hackathon, the FHIR hackathon, under the aegis of HL7 India. And the NRCS was an active collaborator in that. And we have been able to put up this FHIR profiles for the NDHM health data intelligence specifications. So if you go to the NRCS site, I mean, you can get the presentation later, and all the links are mentioned here. So you can see exactly what are the various implementation guides available for the NDHM India profiles, or specifically FHIR profiles for the NDHM. So what are the profiles available there, and what are the extensions? The links are available from the site. And so these are some of the examples, like say encounter or test patient. And this is really something to be worked upon. So people like Bharat who are in this seminar have been playing with these, and there's been a lot of activity going on. As I said, many individuals as well as organizations have been trying to use these, incorporate in their own APIs and try to get with that. So this is how the encounter profile, which have been made India specific. The other thing which is going on, and again, under the aegis of HL7 India, is there's a very vibrant FHIR community now in India. And this community has got technology developers as well as practicing physicians, and of course, health informaticians, all working together, trying to develop better profiles or useful linkages. So initially, of course, as everything happens, it was started as a WhatsApp group, but then WhatsApp does have its limitations, so it has now moved to Zulip. In Zulip, you can see this HL7 FHIR India community, and if any of you are interested, you can also join. So we have Zulip. We also have this FHIR India community in LinkedIn. But for chatting, of course, Zulip is really the place. And again, of course, not all the people who are there in the active WhatsApp group have joined Zulip, but if there are certain important discussions which needs a greater audience, so the summaries are again brought into the WhatsApp group and pointers taken there. And then we have some very energetic people like Kumar Satyam, who actually even put them back in Zulip or paste in WhatsApp and so on. So it's really, really a very vibrant community. And I would urge each of you who's here to come enjoy and have fun. Now, the last part of my talk, as we're saying, how it's being, FHIR is being applied to various other users. So in India, this COVID-19 vaccination is going on in a very massive scale. I mean, India, the population is almost 1.4 billion. So that's a huge number. The scale is unbelievable. So the CEO of the NDHM, CEO of the NHA, Mr. Sharma, he has specifically been saying time and again that FHIR is being applied for this, making this certificates. So FHIR is being applied for the exchange. That's one part. The other part is with the health ID. So this is my vaccination certificate. And as you can see, Aadhaar, of course, was used as an identifier, my identification card. But this has been created, the unique health ID. So now I also have a unique health ID through this vaccination, COVID-19 vaccination. And this UHID will be applicable throughout the NDHM. So this is one of the things which has happened in the last few months, maybe less than 2 months actually. And this is going on. So integration, I mean, you have got so many standards. So harmonization is always a huge challenge. And of course, I mean, everything cannot be scaled up immediately with the scale that we have in our country. But lots of things are happening, lots of disparate things are happening. As I said, diverse stakeholders are coming together, talking, exchanging ideas, may not be agreeing or implementing everything, but I think we are gaining a good momentum. We are going to have a critical mass of HL7 FHIR enthusiasts in India very soon. And I think we are definitely going to make a change, a real change in the digital health scenario within India, the national digital health ecosystem. Of course, for this, we need a health data literate culture right from the top, which we are having, fortunately, right now. And of course, applying models, when we are talking about using FHIR, I mean, sometimes people often loosely use that, oh, we'll use this for that. It sounds nice, but without understanding what it really means. So what we really need to have is more and more interactions like this. This is, of course, at a regional level, but even at national level and state level and lower levels, we need to have more and more consultations and discussions as to how to best use these optimally and make the best utility out of it. So of course, the individuals have to embrace their own weaknesses and find the gaps. So all the 4 characteristics of data literacy, the ability to read, work with, analyze, and argue with data, because critically evaluating the health data is the most important thing, which is often missing. And of course, if we understand our weakness, then definitely we can start to embrace and improve our skills. So I think that is what needs to be done. And already things are progressing in that way. And I think that's the end of my presentation. So I'll stop sharing my screen and we are now open to discussion.
Thank you, Professor. So for the first question, Professor, we have a question from Dr. Alvin. What challenges did you face with introducing HL7 FHIR in India, and what strategies did you employ to surmount them?
There are two ways for any problem. You can try to tackle it either bottom up, that is legalizing things, ensuring guidelines and recommendations. The other is, of course, the bottom up approach. So the legalization is the top down approach and user acceptance is the bottom up. So what's happening here that in this particular case, because FHIR has already been mentioned in our National Digital Health Blueprint, that definitely has encouraged adoption more widely. And as I said, I mean, it so happened that HL7 India also took lead. And like I said, last year, July, about a year back, we held a HL7 FHIR, HL7 India FHIR hackathon. So that was the first, and even Graham Grave had actively participated in that over both the days. So that itself was great. And we now have a very lively community. Of course, what happens in the community, often the people understand more, understand better, and want to implement things faster or in a better way, which often the authorities are not so open to. But because now we have this NDHM Sandbox, so that opportunity is there. We can actually test in real time. Any ideas that we have, we can test in the sandbox. And that is definitely a good sign. So I think interactions, encouragement, and of course, I personally don't think we yet have the critical mass, but I think we are soon going to have it. And then when user demand comes, if you look at the mobile technology, that's what has happened. User demand comes, regulations don't wait. The way mobile technology has expanded globally. So FHIR also, I think that way. And of course, FHIR itself, is very, very convenient. That's why globally, most of the countries are trying to adopt it. So some inherent benefits through FHIR itself. And of course, as I said, both top down, that is, it's a part of our National Digital Health Blueprint, and the bottom up approach that we are having a vibrant community. All these factors together, I think, are really helping.
Thank you, Professor. We have another question here from Dr. Chamika from Sri Lanka. So regarding Zulip, it says you need an invitation to join the Zulip community. Is it possible to obtain an invitation?
Yeah, sure. You can just mail me. My email ID you can share with all. So I can arrange that invitation to you. That's not a problem. And we definitely want more and more people to come and make the community useful. It's really a vibrant community, and I'm sure you'd enjoy being there. Bharat, can you enlighten more about the Zulip? Can you just share your experience? What happens there in the Zulip chat? Because I'm not
there. Okay. Yeah, if I'm permitted, I would add a little bit to what you were saying about the question about the obstructions.
Yeah.
Thanks. So I think Professor Subtain is being the very modest and humble person here, because he's played an instrumental role in getting both top-down and bottom-up acceptance for FHIR in India. He's been a great influencer during the hackathon that happened and the event that happened. We had obstacles, definitely, because at the top level, the Indian government and the Digital India movement, as it's called, strongly believes in what is called the digital public goods infrastructure, largely through a scheme which is using an identity, national identity called Aadhaar. In fact, that stack is called India Stack, and it's also popularly known as JAM, which is Janadhan Banking and Aadhaar and mobile. The strong belief in the leadership in the government and authorities was that is enough for healthcare. And I must say, I'm a student of Professor Subtain in many ways. He's the one, and many others like him, but he's really led the way, I would say, in getting people to gently realize that will not work. And he's been able to influence us, as well as the authorities, And together, we've been able to put in a little bit of word into the authorities. Just as my background, I was the CIO at a leading hospital in Bangalore, St. John's Medical College, and I worked closely with several startups. So also Professor Supten's work has a startup. Guidance from him on how to implement FHIR for the user needs. So I think there were a lot of obstacles at both levels, but Professor Supten has, helped us clear a lot of the obstacles. One more thing I wanted to point out was that we have a very good workforce of people with technical capability in FHIR. The problem that both Professor Supten and I had when we participated in the FHIR session was that technical talent was there, but they didn't know what to do in the Indian context. So we had to actually give them, how to start at the first level in the Indian context. And I think, like Professor Supten said, we are still at a very early stage, but we are making efforts.
Dr. Bunche, because we have been really interacting after a long time. So what have you been doing in Thailand? Can you just share that?
Okay, thank you. Actually, I would like to ask you 2-3 questions. Let me ask you first. Is the FHIR has been used in insurance claim? I know that the Indian government are now aggressively trying to implement the universal healthcare coverage. How FHIR be introduced, or do the insurance like the universal healthcare insurance in India adopt FHIR, and how?
Yeah, not yet. See, digitalization in India is yet, much less than what we would have wanted. So we still don't have any legal mandate to have VMRs or EHRs. So that's not legally required. And that is one of the reasons why, most of the hospitals or healthcare providers are not very keen. Why should we go for it when it's not legally required? So unfortunately, for a country like us, probably top-down works more, unless it's so compelling that the user demand doesn't wait for the regulation. So that way, I think that's why I said, we have a vibrant community who understand the thing, can find the value, but then most of the users, majority of the users are even not aware of it. And then secondly, even if they're aware of it, they said, because another thing which really happens, somehow or other people think that any software should always be available for free. Now, that is something that's very difficult to, I think people who have been working with this would be in a position to say so. Of course, as I said, if it's legally mandatory, then a lot of things happens. HIPAA with all its bad things, but HIPAA was definitely, singularly responsible for a lot of digital health transformations, not just in USA, everywhere. So in fact, GDPR is also trying to do its bit. So in India, what we are having, we are actually coming up with a PDP bill, the Personal Data Protection Bill. That is in the parliament. That was actually tabled in the parliament even before the pandemic struck. And then it was sent to the Joint Parliamentary Committee, and they had done a lot of stakeholder consultations. It was very extensive. So after the consultations, the Joint Parliamentary Committee has recommended, I think, about 89 recommendations. And those revisions have been done. So it's expected when the next parliament actually convenes physically, because now parliament has also been functioning mostly remotely, virtually. So probably we hope to have the act by this year itself. So it will become Personal Data Protection Act 2021. So we'll have a Personal Data Protection Authority under it. In fact, we are not having the separate National Digital Health Authority as envisaged in a National Health Plan 2017, but PDP Authority will have different divisions for the different domains. Health will be one of those. So they would definitely be bringing out a lot of regulations and guidelines. So I think that might increase the pace of adoption. But meanwhile, what we are doing at the lower level, user level, we are trying to find the best use cases, how we can really, because see, interchange of data, that's something very important, and users are now demanding it. It's a global village. Everyone says, today I'm in this hospital, tomorrow I'd be in another city, another country, another continent. I would definitely like to have access to my records wherever I am. And unless it's in an interoperable format, it's standards compliant, that's not possible. So I think the market is moving there, and I'm sure the government will also follow. So we are hoping to have the right alignment soon.
Right. So, Professor Supten, should I add about the
Go ahead.
NLCS effort?
Yeah.
So, if you were referring to the Ayushman Bharat or the Universal Health Care Coverage Scheme of the Government of India, there's a proposal to exchange documents using FHIR. And like Professor Supten was saying, it's a very sort of for namesake use of FHIR in some ways. It's not really exchange of data using FHIR. So basically, they've specified six records, right? The diagnostic report, the discharge summary, the health document, immunization, OP consult, prescription, and wellness documents, which will be exchanged using FHIR 4.0 or 4.01. That proposal is there, and that is the sandbox, as Professor Supten, some work is going on that, and that might emerge, or the effort that we are making right now together to get it more data rich than just exchange of documents is what we are working towards. I hope that answers some of the questions.
I think Jürgen would like raise the hand. So Jürgen, could you unmute and talk?
This is Jürgen Darmstädter from the Global Consortium for E-Health Interoperability and IIG. Thank you for this excellent presentation. I want to make you aware that in 2 days, actually, we have a listening session on COVID vaccine credentials. And one of the speakers is Mr. Lav Avagar from India, and the others are government representatives of Japan and Hong Kong. And my question is, I know that you have presented now the COVID certificate from the MOH in your presentation, but I know that there is also the DIVOC initiative. I recently heard a presentation that they also have issued, I don't know, many millions of vaccine credentials. Could you please explain how these two very large vaccine credentialing initiatives work together in the Indian country? So, I mean, is there in terms of acceptance of these certificates, you know, are they both equal, or, you know, can you explain how these two projects play together? Thank you.
One is the vaccination. What is the other?
It's both on vaccine credentials,
Yeah.
certificate, you know, and you presented the one certificate from the MOH, but there is also the DIVOC initiative. It's an open source vaccine.
DIVOC.
Okay.
DIVOC.
DIVOC. Yeah. We heard that.
It's based in India, and they have said lastly that they have issued, I don't know how many millions of certificates. And I was wondering how these two projects are playing together in India.
Actually, I am not aware of the DIVOC project, so I won't be able to comment on that.
Oh, okay.
The certificate which I showed, that is actually the official one, which is issued by the Ministry of Health. So we have a co-win. I mean, so that's winning against COVID. So the co-win portal is there where the registration is done. So vaccination, the official vaccination actually is not done if the registration is not there. In fact, in India, sadly, we have had a few cases in different states where there's been cases of fake vaccination. I mean, they didn't register there. They created other apps and registered, and ultimately it was found that those were all fake. So it's really scary at times. I mean, technology is a double-edged sword. So sometimes people often take whatever is said on face value, but that I think is very important. But the one which I shared, that is the official government of India thing, like EU is now giving green pass. So some of the countries had not cleared one of the vaccines from India, the Covaxin. But some of the countries individually, I think about 10 countries have already said, no, that's acceptable. So, of course, right now they have given the data to WHO also. So once it comes in the WHO list, maybe things would be easier. So this is a global phenomenon. So there are lots of requirements for global interactions and global endorsements. And I think there definitely a global standard, usage of a global standard is always desirable and beneficial, because Otherwise, I mean, this, as I said, I mean, it's a sad incident, but in India, there have been many cases in different states where there have been cases where people were told that they are being vaccinated and a certificate given, but ultimately it was found that it was not the right one. I mean, doubtful. So, I mean, technology and fraud somehow or other also go hand in hand.
I think Lankika, could you would you like to ask the question that you post in the chat?
Hello, thank you very much for the opportunity. I want to know regarding the vocabulary. So for the COVID vaccination certificate or the instances that you are using FHIR, do you use specific vocabulary that is data dictionary type thing for India, or use the words from the FHIR vocabulary itself? Like for the patient, do you give your own definition and have a data dictionary with you, or like we say, like UHID, do you have your own definition, or you use the patient definition in the FHIR as an example? So on for the other data elements, what is the definition you are taking? What FHIR gives, that definition, or you have your own data dictionary with you?
I actually don't know the answer to this question, so I would not be able to answer. Maybe if you can mail it to me, I'll try to find out the answer, and when I get it, I'll let you know. Now I get this DIVOC. You have shared the link. Thank you for that. So this is the portal. I mean, here also what you are downloading is the same certificate. So the certificate, as I said, I mean, we have a DigiLocker that can be stored there also. So Government of India has done this. I mean, that's the governance, the ease which has been there. The same document can be stored and downloaded from multiple places. The document is the same. So it's, the source document is not different. Just the different places from where you can download and print, and that it's just another portal for downloading. But the one, as I said, I mean, the one which I showed, I mean, of course, I had downloaded from the CoWIN portal itself, but if I go to the DIVOC, I can download it. Will be the same. I mean, it may look slightly different, but the content will be the same.
Yeah, they're using APIs to get the data from the government portal.
Okay, Bharat didn't get from the DIVOC portal, so maybe you can.
No, I tried it out, but I do know that they have published APIs for getting the certificate, and those are protected APIs, and certain companies, certain portals have been allowed to download the certificate through those portals as well. But it's the same certificate, like Professor Supten said.
Just to answer your question, Dr. Supten, how Thailand works. I think we also have several challenge from getting a kind of the mandate from the top down. So we also working at the bottom up, like we create a community, the FHIR communities, and also I work with another academics institutes, the passionate informatician from Ministry of Health, and we just get into a group, not very formal group, we call Standard and Interoperability Lab Thailand, and we kind of trying to, like the sandbox for the FHIR, introduce the community, expand the community, like to the developer and also to the policy maker and the people who are interested in that. FHIR is a very, I mean, it's a buzzword.
Yes.
Everyone say, okay, we can do the exchange with FHIR, but they don't know FHIR.
What is
they don't know why. It's very difficult if we don't have a kind of the knowledge, and I think the dirty hand working on the real thing. So
absolutely.
What the Standard and Interoperability Lab Thailand try to work on it, similar to you, find the use case. We are seeking out the small grant from to develop a project that can be, I mean, showing or at least expose the standard API by FHIR that can be linked, that can link the information from one institute to another institute. And I think the most success is that I can introduce FHIR into several groups. Even they don't know much. It's kind of we kind of in the elementary school of FHIR. We have to learn more. We have to kind of see FHIRing how we gonna create profile, create implementation guide or something like that. And
it's hard work. It's definitely hard work, and unless people get into it, obviously they don't appreciate. I think Dr. Pramod is back. He's putting some comments in the chat box. Would you like to speak and share your experience, your FHIR experience in India?
So first, to answer the question about the profiles that we've been making for India, we actually have a FHIR community, an Indian FHIR community, who has been working through modifying the profiles. I've been looking at the international profiles and modifying the elements to suit India. And I think they come up with profiles for patient, for provider, for facility, and so on. Of course, it is an always evolving. It's an always evolving process. And the second example I would like to give is for the vaccination, COVID vaccination, being able to send across vaccination details through the immunization profile for FHIR immunization profile. There's an organization called National Resource Center for EHR standards, and they basically had a committee or formed a subcommittee of folks who were knowledgeable about it, and we went through the sort of immunization profile in the FHIR and modified it for India. Brought in factors, for example, like the batch number or expiry date and stuff like that, elements into that. So that's how it is modified. There is a sort of process that is followed. In fact, they have posted most of those in the website, where you can have a look at the different sort of profiles that are up already. And the ones that are really up right now, as far as FHIR bundles are concerned, is diagnostic report. Then there is the OPD consult, the discharge summary, and there is prescription or medication. The medication. These 4 profiles are up, along with the resources that are concerned with them. I hope that answers the question.
You would like to share also your activities, because FHIR community is quite active, and you are one of the most active leaders probably there. Like you're doing the LOINC work right now and so on. So can you just share? Because with your background also, you are a clinician turned informatician. So we don't have really many people like that. And again, user adoption. that was one question which Dr. Bunja had asked earlier. So if you can just share your experience in a nutshell, that would be very helpful.
So to begin with, if you look at FHIR is basically the envelope, right? But you have to have the content that comes into FHIR, which involves that there is certain sort of standards that are adopted in the different walls you build. For example, in lab systems, or if you're sending over a diagnostic report, it has to have the LOINC embedded within that report, right? Whichever way you can do it. So right now we are working on that vocabulary, for example. I wouldn't say it's vocabulary standard, whereby we are having our lab, various lab chains, our various laboratories, helping them to try and adopt LOINC. And it's a whole process, because in LOINC they are so specific about how you will assign a ID to a LOINC test. The units have to match. There are so many 6 different factors that have to match. So right now we have a working group, and Bharat actually is one part of the working group, where we meet every once a week, and we actually are working on the most common lab tests to begin with. We are taking the top 100 first, and then we are going to start, actually mapping them out in such a way that we come up with a curated sort of Indian database, looking at the tests, because there are certain tests in India which are sort of the units are very Indianized, right? A classic example would be, say, for example, platelet count. In platelet count, while internationally they say, give the number per whatever deciliter or something to that effect. In India, we might have a unit, something called lakhs per cubic millimeter, and lakh is a very Indianized sort of. So how do we bring in a LOINC code that would suit those sort of variations? These are sort of steps that we're working through. Fortunately, we have a group of experienced pathologists and who understand that and are trained in LOINC, and therefore are helping us with the mapping process. Once we finish the first 100, then we'll move on to the next 500 most common. And then we're also working on a script which will help the local laboratories be able to automate as much of their tests as possible to the line code, looking at the way they call their, the way they name their tests and results and so on. But then, of course, there'll be a little bit of a manual process in that also. And then finally, once we get this done and have the script also working along with the support system, we'll then hopefully work with the integrators who are sort of certified by the National Digital Health Mission to start adopting it. I mean, this is the hope, this is the dream. That's what we're working towards.
Dr. Step also talking about the e-pharmacy. How about the vocabulary for the drug? Do you have to kind of develop or mapping the drug code for this
for that,
EMR?
Actually, there is. Yeah, for that there's a sorry, Supten, is it okay? Can I answer this?
Yeah, so, go ahead. Actually, there's an India drug code extension done by NRCS.
Right.
So
they're working on.
Go ahead on that. Yeah.
They're working on the SNOMED hierarchy basically at the foundation, and then for the the upper levels of the package ID and all that, they will be adding what is known as the common drug codes of India. And in India we have over 200,000 of them. I think they've finished about 50,000 of them. To the package ID level also, beyond the generic and dispensing generic and so on. And that is the work that is going on. So that is work in progress. Yes, but we are working towards that.
The experience similar to Thailand, but Thailand might, because maybe you are Indian is a very, very big country.
Yeah, size, that's the scale.
Many
daunting scale. Yeah, 1.4 billion population is.
And it's quite a very big challenge to kind of getting people to kind of the scale. Come together and come with the consensus. Thailand also similar thing, and we
they have done that. I saw the
we might be a little bit lucky that we work for the drug terminology or vocabulary for at least 7, 8 years or 10 years, and we can push it into the requirement for the reimbursement. So the claim have to be used this kind of the standard vocabulary. And now in these 1 or 2 years, we are going to implement it. The Thai medical laboratory terminology, which is the LOI, modifying LOI. And Thai medicine terminology is also the extension of the SNOMED. And right now we are going to proceed on the using FHIR. So you can see that it's correct that it envelope and also the content. The vocabulary is very important too. So we have to work in many fronts in the bottom-up style, and it's very hard to convince people or to put the resource to developing this. And this is just to give you the context in Thailand. And at first I very jealous India that you implement and you adopt SNOMED CT since 2014. Thailand still not adopt and be the member of SNOMED CT. But I know that to implement SNOMED CT into the system, it's quite a challenge also. I think Dr. Alvin.
Yeah, I think he was raising his hand. Dr. Alvin, go ahead.
Yes, I wanted to ask, who is in charge of publishing the implementation guide in India? Is there only one implementation guide and that will be used by everyone? And how many FHIR servers are there?
Yeah, actually the National Resource Center for EHS Standards, which I said, it's in CDAC Pune. So they are entrusted by the Ministry of Health and Family Welfare to act as the National Resource Center for EHS Standards, anything related to that. They are also the National Release Center for the SNOMED CT. So India National Release Center is the NRCES. So that's why, they are the ones who are doing earlier also, in fact, when HL7 India was formed, I had been one of the earlier presidents in HL7 India as well. That was a decade back. Initially, we had thought of putting CDAC Pune as the headquarters for HL7 India, but then that being a government organization, there were some issues. So we had to form a society and get it registered separately. That's how HL7 India came into being. But they have always been working with that. So HL7, DICOM, and SNOMED CT, all are being coordinated through the National Resource Center for EHS Standards, and they are the ones who are publishing the official implementation guides.
So Professor Supten, after having
Like
gone,
for FHIR HL7 India is a partner in that. So it's NRCS, HL7 India together like that. Yes.
after having gone through the journey, what would be your advice to other countries regarding HL7 FHIR? I mean, there's a lot of discussions and interest right now, but where do we start? What do we need to do? Step one, step two, step three. Maybe very simple things that they can already do if they want to implement a FHIR system in their country.
Yeah, I think Dr. Bunchai mentioned that very nicely. I mean, there are so many things which can be done. We need to look at it because, as Dr. Pramod also said, FHIR is more of an envelope. It's the content that matters. But I think, I mean, if you ask me the first step, I always talk about this health data literacy. That is very sadly missing, not only among the end users, but most among the policy planners. I mean, they don't know. Like I said, I mean, you can just go and say, oh, yeah, I'm using FHIR. What is FHIR? What do you do with that? No one knows. Others say, no, we are using FHIR. So first thing which I very strongly think is everyone should know what is it and what is it not. That I think is the most important thing. Once we know that, like Dr. Pramod gave some excellent examples, how we can really use it. And we have to get the domain experts for each. I mean, when we are dealing with labs, obviously pathology experts, when we are dealing with other things like that, unless we get in the domain experts and show them the value. I mean, what is the value in getting? Because everyone asks, ultimately, it's human nature. What is in it for me? I mean, why should I use it? So if it's legally mandatory, I have to use it without asking questions, but that's not the best way. Whereas this bottom-up approach, as I said, user demand, when they find value, they said, yeah, if I use it, it's useful. Actually, I can treat my patients better. The health outcomes are better. Then we are going to use. So I think the first step I would say is to know really what it is and then consult, discuss like this sort of thing. I think this 1 hour was really very, very useful. And I think a lot of us, I mean, all of us learned a lot of things because we were hearing diverse viewpoints, different settings, how things happen. And we have to start small. We have to start small. We have to start in a comfort zone, then gradually expand. FHIR is definitely a very useful tool, but doesn't mean it's a panacea for everything. Obviously, it is not. So that unfortunately people don't understand, particularly policymakers. So I think, in fact, Dr. Bunchai is a policymaker. If he takes off his informatician hat, how do you really accept this challenge? Dr. Bunchai, you would like to shed some light?
I think you misunderstood that I'm the policy maker. Actually, I am the kind of they look at me as the academe, and I have to push a lot of things. Try to have their ear for my recommendation, and also like you said, how we are going to kind of show the values. They just look at this. The surface and just want only outcome value, but they don't know how complex and how complex of the underneath and how
outcomes also. I think they're looking at the low-hanging fruits. I mean, most of the policymakers are looking at the low-hanging fruits. That's immediate achievement.
That is we kind of put up a lot of money on the low-hanging fruit, but it fail every time. But they still want to low-hanging fruit because of they are the politicians, or they are the policy maker at the that position, and they are going to go up. So they just want the quick outcome. So that is a kind of the vicious cycle. So it needs people like us that kind of crazy enough to work, still working on this for 5 years, 10 years, 20 years on it, and not give up. I think that what we have to find the people like us to be more working on that.
Absolutely, the people. It's really people that make it. I mean, successful or a failure. It's ultimately it's always the people, and even in the policy making domain, whether it's a politician or bureaucrat, it depends on who is sitting on the chair. It sometimes becomes very individualistic. So some people are very forward-looking. They want to look at long-term returns, but you have to wait for that to happen. Meanwhile, as I said, we can have our own community. We can show them the good showcases. I mean, use cases which have done well. What's the value addition? And I think hope for the best.
We have our friend from Japan, Dr.
Okay.
Shinji. Any comments or just or you come in just between? Any comments on the fire in Japan?
So fire in Japan is still a preparing stage. Not someone challenges the feasibility of interoperability between system to system or inter-organization, but not. We are now discussing about the JP core guideline, JP implementation guide for prescription or lab test or summary and so on, but not established one. Just a preliminary stage. Hello, Buncha.
I think it's similar to many countries. I think so. Don't be discouraged to all of us in this community. We are on the same the same step. No, we have to kind of hold our hand together to go to the destination. But I think exchange knowledge between us all is a good way to that we can learn. Every country has their own context, but we can think that the good way that we come together and learn about it. So I think we reach.
This is also a marathon, like you run, so only 5 kilometers, 5 or 10 kilometers just started, but we have to go Tokyo Marathon, like.
Thank you. Would like to another time. So I think Cha, I think we reach the end of the hour.
So once again, thank you, Professor Suptendra and Dr. Bunchai, also for our participants for actively participating in tonight's webinar. So see you again on July 29 at 6 p.m. Manila time.